as many of you may have heard and or remember, today we have Dr. Sarah Spencer, who has done a couple different echoes for us. She is an amazing advocate in addiction world all the way up in Alaska. So she's at a conference though today, so I don't even know what time it is I don't even know where she's at. So in Alaska, it's probably super early in the morning yet. All right. Upcoming echoes, Sarah Pauly is coming back next week. So she was with us last week, talked about cannabis, is going to come back talking about youth and opioids. I know a couple of you had asked about her doing the pregnancy cannabis talk, and we have been in discussion with her. She is working on connecting us to someone who would probably be a little bit more better suited per her. So we're working on that. And you can see we have quite the variety of kind of all over the place people. Some of these are even more quite exciting. We stole them from Atlanta, so people from around the country. I am going to comment really quickly on the June 14th one, Eddie, talking about harm reduction and what's going on in Minnesota. An amazing thing just passed through yesterday. I'm not going to go into the details with House file, but stay tuned. A lot of things are changing to kind of help patients in our state be better taken care of rather than just punished for their disease of addiction. Kurt, you're muted.
Man, I'm having trouble today technologically. But yeah, just remember there's free CME. Again, Sarah would love to see your faces, so please feel free to turn on your video so she can talk to people and not little black boxes. So keep that in mind. But yeah, you can go to the CORE website. And again, Katie's going to send you something for the CME. You have to fill that out to get the CME.
All right. And so technical assistance, again, we're always here for any kind of questions you might have, anything related to addiction. Sounds like a lot of mental health going on as well, and co-occurrence, especially in fentanyl world. There's our cell phone numbers, Aaron, our nurse's cell phone number, as well as Aaron's email address. But never hesitate if you want to chat a question in here. We can give you our email addresses as well.
And again, the CORE website is up. The manual is up. So if there's things from the manual that you need with some of the resources that are actually in that, especially in the appendices, go ahead and take a peek at that.
Okay, Sarah, I don't know if you are there yet, but I will take down my slides here in a second. But Sarah's going to talk about the 2022 CDC guidelines. We've talked a lot about the 2016 guidelines, especially a few years ago, and had commented. We actually have a talk coming up in the next few weeks at some point here about the intersection of what the CDC guidelines say and what the Minnesota state prescribing guidelines are. Couple little tiny nuance differences, nothing significant, but we'll kind of talk through that and what the state of Minnesota is doing. But the CDC guidelines, of course, had gotten a lot of kickback with, people not loving what the guidelines were showing. And so they kind of updated a little bit of their guidelines just last year.
And a lot of the stuff that's on the state thing, actually, the papers that were actually used to kind of help guide what happened at the state. We're going to discuss some of those too as well. So that'll kind of be a follow-up to Sarah's talk today. And it looks like she's back.
Hi, can you hear me okay?
Perfectly.
Yes.
Okay, great. Okay, so let me see if can I share my screen?
Absolutely.
All right.
She looks like she went to her car because it was quiet.
That's exactly what I did. I'm going to a meeting out of town today, and so I don't have like a easy place to do this from, but hopefully this will work here. Okay, are you able to see the slideshow okay?
Yeah, perfect.
All right, great. So we're going to review the new CDC 2020 guidelines for manage opioids for pain. And some of the topics we're going to cover, we're going to review some of the really unintended consequences from the previous 2016 guidelines and talk about what some of the risks are to rapid or non-consensual taper of opioids or discontinuation of opioids, and talk about what times, what are when you might want to use opioids, and if it's worth it or not, and how we can talk with patients about some of the risks and potential benefits that opioids could serve, and how we can try to reduce the harms of opioids. I don't have any financial conflicts of interest. So in 2016, the CDC, they came out with these guidelines that were really seemed like they were pushing us to cut down opioid prescribing. And as a medical profession, we did a really good job. We've done a really good job at cutting down on opioid prescribing, but that has not resulted in a reduction in opioid-related overdose deaths. And so when I think about this, I like to think about it like a forest fire or wildfire. The medical profession played a part in this kind of perfect storm of overprescribing of opioids from the mid-90s to the early 2000s. And that really set this fire. It lit this fire with the other issues that were going on at that time. And especially with the prescribing of large quantities and excess quantities for acute pain, and that these excess quantities of pills really ended up in the wrong hands. And then those triggered this increase in opioid use disorder. And then when we started cutting back on our prescribing, right at that same time, ultra cheap, super potent fentanyl came on the market, and it immediately filled that void and just further fueled the fire. So we tried to do our part in cutting back on prescribing, but that is not going to stop this wildfire. We need to actually do other things as far as making sure treatment is available for people with opioid use disorder and other issues like that, to actually try to put the fire out. And so these recommendations are meant to apply. They address both acute and chronic pain, but they are not meant to apply to people who are for palliative care situations, end-of-life care, and they also specifically mention sickle cell disease. But the areas that these recommendations address is determining whether or not you should utilize opioids for pain, how to select appropriate and safe dosages and formulations, and how long we should be prescribing that, and how to follow up on those, and addressing the particular potential harms of opioid use. And these were they all have different levels of evidence base. And if you want to look at the guidelines, they go deep into the evidence behind each of these recommendations. And really, what they really wanted to change here is what happened in 2016 is that associations, state and local governments took these guidelines as being strict regulations, which they were never intended to be. So there were states that created laws around how much opioids you could prescribe and for how long, specifically related to these guidelines. And these guidelines were never meant to be strict and hard set inflexible standards. So this practice guideline is meant to be a general recommendation and to provide information that we can use to improve our communication between us and our patients about the risks and benefits of pain treatments and how we can kind of maximize the benefits and reduce the risks when we're treating pain. So we're just going to dive right in. We're just going to make a brief summary of recommendation by recommendation. I think there's 12. So the number one recommendation under the topic, whether or not to initiate opioids for pain, is that we know that the evidence shows that non-opioid therapies are at least as effective for acute pain as opioids are in many circumstances, and that we should really consider these risks and benefits and talk about them with the patients before we decide to prescribe opioids for acute pain. And there have been a number of similar studies that have looked at pain, and mainly like in the emergency department, looking at pain like in people with fractures, orthopedic type pain, that we know we can kind of understand, the severity of that pain, and how, random double-blinded medication administration, how it affects that pain. And a number of studies have shown the same thing, is that actually the combination of ibuprofen and acetaminophen is significantly more effective than oxycodone or tramadol or a number of other opioids. So the non-narcotic, non-opioid medications actually can be very effective in treating acute pain. And whether we're prescribing opioids for a few days or months or longer, we need to make sure that people understand the risks associated with those medications. And there are a number of pre-made educational tools that you can distribute to your patients. So this is one I think that the CDC puts out that is sort of a one-pager that you can share with your patients when you're having that discussion about how to safely take their medications and risk associated with their medications. For subacute and chronic pain, also non-opioid therapies are preferred. There is the evidence that opioids help with chronic pain is pretty minimal. And so we should really only consider initiating opioid therapy when the expected benefits outweigh the risks for that patient. And, we've tried the other things and they are not working, or they're unlikely, they're not possibilities for those patients. And also, from the very first time that you prescribe opioids, you should have an exit strategy. And the patient should understand what the expectations are from treatment, and that we should have a plan to, like, if this isn't going well, if these medications aren't working well, we have adverse side effects, there's misuse, what is our plan to discontinue them? We should think of that from the very beginning. And as far as evidence-based treatment of chronic pain, first of all, there's no medication that has a high level of evidence that's effective for chronic pain. So, but opioids probably have the least amount of evidence. So our first line, it depends on what kind of pain it is. Are we dealing with nociceptive pain, like arthritis, like localized pain? We can point a finger, we know what's causing it, where the first lines are going to be things like acetaminophen and NSAIDs, versus neuropathic pain, where our first lines might be gabapentinoids and TCAs, topical treatments when they're needed. And many of the non-pharmacological interventions, especially Tai Chi, yoga, CBT, and ACT, have as good or sometimes better evidence of helping with chronic pain than some of our medications do. And unfortunately, they may not be covered by insurance, and they may not be available in more remote and underserved areas. But if you have access to a pain psychologist, or patients are fortunate to have access to some of these other modalities, they may actually be more effective for treating their chronic pain than other medications that we can offer. And when we talk about people about what the adverse effects are of long-term opioids, Obviously, overdose is a risk, but what we see more commonly are other issues, and some of them that maybe we don't talk with patients enough about, I think. Sexual dysfunction. So we're going to see a reduction in some of our sex hormones like testosterone, and issues with opioid-induced hyperalgesia, that there's a significant risk, and we don't totally understand the amount, what proportion of patients will develop this or why it happens, but a significant proportion. It might be the 1 in 10, it might be 1 in 2 or 3, that maybe somewhere between 5 to 20% of patients who are prescribed chronic long-term opioids may develop this opioid-induced hyperalgesia. So people understanding like there is a significant risk that this medication may actually make your pain worse in the long run. Many patients that I've seen have complained of just this cloudy headedness and cognitive impairment. And in many cases, actually, they don't realize that until they have maybe switched to a different therapy and reduced or stopped their opioids, how much effect that was actually having on their cognitive function. And opioid use disorder is a very, very real, significant risk of chronic long-term opioids, especially the longer they're continued and the higher of dose. There are studies that show, 1 in 4 patients who are on chronic high-term long-dose opioids might develop an opioid use disorder. That is a very, very significant long-term risk that can have very serious impacts on that person's health and wellness and quality of life. And when we're thinking specifically about the source of pain, when people are having what we would call nociceplastic pain, which is, these pains that we don't understand why they happen. There's something happening with the way the body is regulating the neurological system. These kind of diffuse chronic pain, fibromyalgia, these kind of diffuse chronic pain symptoms that we really don't understand. Those, nondescript low back pain with no obvious source, like these types of pain have particularly poor response to opioids. And so that's really a situation in a chronic pain situation where we should consider not using opioids, even if other things aren't working, because they really don't seem to have a good effect on this pain, and also seem to have more adverse effects, more issues like opioid-induced hyperalgesia and that sort of thing. Recommendation number 3 is that we should always start with immediate release opioids. We should not be using extended release opioids when we first start prescribing for either chronic or acute pain. Extended release opioids have more risks associated with them, and especially when people are first starting them, they may be more associated with adverse effects. So start with immediate release and only switch to extended release when you have people have been on them for a while and you have a very good solid sense of exactly what that dose should be, and also know that this person is not, that this is a long-term plan. It's not a short-term plan, that this patient is going to be on this medication for the foreseeable future. That's sort of the only time that we should think about switching to extended release products. And when we're starting opioids, we should prescribe the lowest effective dosage, and really use caution every time we're increasing the dosage to try to decide whether this is really, is this likely to continue to benefit the patient or not. And when so now, like with these guidelines, instead of saying like don't prescribe more than 90 morphine equivalents, we know that cutoffs of like 50 or 90 morphine equivalents, they're are sort of where the risk bumps up, and especially over 90. In many cases, where the return we're going to see is going to be diminishing and the risk is going to be increasing. So those are the times when we get to that situation where we're increasing, we are likely to see diminishing returns with increasing risks, and where we really need to have caution as far as further increasing those dosages. When we do get to a point where we are maybe opioids aren't working so well, or someone's been on them for a long time, and we want to look at the possibility of switching to another opioid, which can improve pain control and possibly reduce opioid-induced hyperalgesia. The highest risk times for people for adverse events, especially overdose, is when you first change the dose or you first change the formulation. That first week or so after doing that, that's the highest risk time. So when we make these switches, we really want to underestimate the dose. And we can always go up from there, but we always want to underestimate by about at least 25% if it's a low risk patient, or 50% if it's a high risk patient that maybe has other comorbidities, they're frail, other CNS depressants they're taking. And this is based on, you want to use the opioid conversion calculators to make these conversions. And really, if you have someone that you're thinking about switching them to methadone for chronic pain control, really in those situations, you really need to way underestimate the dose of methadone, because there is no really good, the methadone metabolism is so complex. There's no good formula for making that conversion. So we're going to way underestimate, and we're going to make sure that patients know that it's very, very dangerous to take methadone as a PRN pain medication. And we're going to wait at least ideally like a week, 5 days or so between dose escalations, because it takes a number of days for it to reach steady state. And if people are taking extra PRN doses, or we're at escalating that dose too much, a number of days later, it could become a fatal level of methadone in that patient's system. The next recommendations is that if patients seems like the risk for this patient far outweigh the benefits, or there's other issues in which this medication really is no longer safe at this dosage for this patient, we should work closely with patients to work on gradually tapering or switching to safer medications. What we found is that there's been a number of studies that come out in the last few years, is that if we discontinue opioids or taper them rapidly, it is much more dangerous than just continuing the opioids. And so we've seen a lot of really adverse outcomes with increased risk in death and suicide from rapid or non-consensual tapers or discontinuations of opioids. So we should never discontinue or rapidly taper unless there is an acute life-threatening concern. A study came out a couple of years ago looking at patients in Medicaid patients in Vermont who were on high-dose opioids and had rapid discontinuation. And rapid discontinuation was defined in less than 3 weeks that they were discontinued. And actually, the vast majority of those people were just cut off with no taper. And about half of those people who had rapid discontinuations were hospitalized because of the adverse effects related to that. And we know that the longer the taper, every week longer that the taper was, there was a 7% reduction in the probability of an opioid-related adverse effect. And although actually the majority of the patients who did have their opioids discontinued rapidly, also were diagnosed with an SUD, which might have been the reason it was discontinued. The provider found out, hey, I think this person has an opioid use disorder, so I'm just going to stop their opioids. But almost none of them were then transitioned to medications for opioid use disorder, which is the treatment of choice. That's how we're going to help those patients and reduce their mortality, and also help them treat their pain, is by switching them to another opioid agonist to treat their opioid use disorder, but that oftentimes doesn't happen. The VA published this information about suicide risk in people whose opioids were discontinued. And they found that people who, especially if they were on opioids for more than a year, when those opioids were discontinued, their suicide rate went up dramatically by like fourfold or more when their opioids were discontinued. Especially that first month after discontinuation is a really high risk time for suicide. And what we've seen increasingly in the last 5 years is this population of patients that have been termed opioid refugees. So these are patients who have been prescribed opioids, they are physically dependent on them because they've been prescribed them, and then something happens to them. They move, they lose their prescriber, often through no fault of their own. Their prescriber might have died. Maybe their prescriber did get in trouble and lose their DEA because of irresponsible prescribing practices. But that doesn't mean that the patient wasn't doing their part in taking the medications prescribed. So often these patients might be in a situation where, of no fault of their own, they are now left in the lurch with no prescriber for their opioids. And this is really a dangerous situation for these people because it's not safe for them to rapidly taper, and so few practices may be accepting new patients to continue opioids. They're just told no every phone call that they make, and they can't find a new prescriber to continue their care, and they may end up in the hospital or with severe medical or psychological consequences from this. So when we think about patients who are taking high dose opioids and how to manage them, especially if you're inheriting this patient who has lost their prescriber, the right thing is to do probably is that you should take care of them. This is a very serious opioid dependence. Even just physiological opioid dependence without opioid use disorder is a really significant medical issue, and these people need care, and we shouldn't just be turning them away from the door. We should be accepting them and providing them with the care that they need. And there's many different approaches. If the patient appears to be benefiting and they're taking their medication as prescribed, and there's no obvious immediate risk, and they are not currently willing to reduce their dose, then the appropriate thing for that patient might be to just continue the current dose with close monitoring and getting other specialists involved that may need to help you take care of that patient. We can talk with the patient about doing a slow taper over time, and when we're tapering, we're going to do it very slowly, like 10% a month or less, generally for most patients, unless the patients are wanting to do it more quickly. If we're going to do a rapid taper, that should only be for immediate life-threatening issues, and that should be done in the inpatient setting. It's really not safe to do a rapid taper in the outpatient setting. Or following along with recommendation 5 of these guidelines, when it comes to discontinuation, if we have patients who are sort of not willing or able or tolerant of a opioid taper over time, or they just have far too much risk, they do have high risk to their safety, and it really is not safe for them to continue their regular opioid, then we can switch them to buprenorphine for treatment of their chronic pain. And that specifically is in the current CDC guidelines. And we should try to prescribe for a shorter period of time as we can, especially when we're looking at acute pain. We found that especially when we get in that first 10-day period, there's a real kind of dramatic increase. Like every day longer that we prescribe, the risk of chronic opioid use goes up. So that's why some states have, tried to institute guidelines on the number of days supplies and things for acute pain, and some guidelines have been issued, consensus guidelines from some institutions about how many opioids, how many pills should we give people who are having, for example, like some of these common outpatient surgical procedures, and the consensus is, we're prescribing too many pills. We should start with fewer pills, maybe 10 to 20 pills, and then we can always refill them if needed. But in many cases, patients aren't going to need a refill or want a refill. So start with a lower number, so to minimize that risk, and also to minimize the risk of the medication falling into the wrong hands if it's not used. The next guideline, we should continue to reevaluate the benefits and risks of the opioid therapy patients, especially early in treatment. So if we decide, okay, yes, we're going to give you chronic opioids for your chronic pain, we shouldn't just be handing them a 1-month supply to begin with. We should start with short periods of time of like a week at a time, and really make sure that patients are benefiting from this, that they're not having dangerous or intolerable side effects, and monitor these people on a regular basis, not just keep blindly refilling these prescriptions without reevaluating the patient. we want to, on those reevaluations, we want to make sure that the patient is actually making progress towards their functional goals. Why were we starting this medication in the beginning? And are we meeting the goals that we had intended when we started the medication? Looking to see, if we need to adjust the regimen, address breakthrough pain, address the most common side effects that are going to come up, like constipation, endocrine dysfunction. And watching out for significant issues like this, like opioid-induced hyperalgesia, which is a phenomenon we don't totally understand, but we know that it occurs in a significant percentage of patients, and it causes this really increased sensitivity to pain that tends to be more diffuse. The pain tends to start appearing in new locations that it wasn't in before. Patients just in general become much more sensitive to ongoing stimuli, and despite this escalation in dose, the pain doesn't seem to be getting better controlled. And so this is a situation in which a patient really, the only way to really improve pain in this situation that we know of is either to reduce and then gradually with the goal of stopping opioids, or possibly to switching to other families of opioids, or switching maybe to buprenorphine, which would be safer. And we should discuss patients' risk mitigation strategies, like offering naloxone. And so making that part of your routine prescribing practices, or if you have a state program to be able to hand out naloxone like we do, to just hand it out to patients. They recommend that you do review the prescription drug monitoring program in your state to evaluate for other issues that you might not be aware of, like the co-prescribing of other CNS depressants like benzodiazepines. And if it's good to know how to get naloxone in your state. I see your state has this website where you can find out where there are partners that will distribute naloxone free of charge, and which pharmacies carry naloxone, hopefully most of them. They don't actually make any specific recommendations around drug testing for patients. So they, similar to ASAM, I think recommendations is that we need to consider and discuss the risks and the benefits of toxicology testing. And so I think it's important when we think about drug testing. Drug testing is a tool to assist us in communication with the patients. It's not meant to be a way to police patients, and it's not shown to actually improve outcomes. And so so it can be an important tool, but we should be using it in a way that's going to help us to serve patients better if we're using it, and understanding that it's not something that is proven to improve outcomes. When we are prescribing an opioid and the patient is taking an opioid and benzodiazepine together, we need to have a heightened level of caution. And again, this is, trying to say, like, we shouldn't just immediately stop the opioid or immediately stop the benzodiazepine. Both of those are quite traumatic and harmful to patients, but we need to make sure that the patients understand those risks and to address those risks, and that addressing that risk may be in the long term that we try to switch one of those medications to a safer, or we try to taper one of those medications. Tapering them both or stopping them both at once can be really intolerable, dangerous to patients. But to really understand that there's significant increased risk with combining those medications together. And we need to watch out for red flags that would lead us to consider that this patient might be developing an opioid use disorder. And so remember, again, a significant amount of patients that are prescribed chronic opioids, especially chronic high-dose opioids, will develop an opioid use disorder. So looking for those red flags of, running out of overtaking medications, and not using medications as prescribed could be concerning, that they are indeed developing an opioid use disorder. And this is the DSM criteria. People are not able to control their use of the medication, and it's causing them problems. So now, thankfully, we all all prescribers that can prescribe Schedule III medications can now prescribe buprenorphine. And we can prescribe buprenorphine both for chronic pain and for opioid use disorder. And it works, it's something you can use for both. And you can, although there are 2 FDA approved products for treating chronic pain, the 1-week transdermal system and the Belbuca, which is the mucosal system. These are brand name medications that can be quite expensive, and they're also at a lower dose, and they may not be covered by the patient's insurance, and they also may not be at a high enough dose to actually provide adequate pain relief for patients. So it's 100% legal to prescribe sublingual buprenorphine for chronic pain, whether or not it has naloxone in it or not. Naloxone is just an abuse deterrent. Many opioids have pills have abuse deterrent features. It's just an abuse deterrent feature. So those formulations of sublingual buprenorphine are 100% legal to use for chronic pain. They're just off label. And so you may have to deal with insurance prior authorization issues around that. But these guidelines really specifically state that even in opioid use disorder, absolutely, we should be offering medication to treat that. But even without a diagnosis of opioid use disorder, transitioning to buprenorphine for pain should be considered because it can reduce the risks associated with therapy, especially respiratory depression risks compared with full agonists. So it's just a much safer medication. So if we have patients who we have significant safety concerns for, even if they don't appear to have opioid use disorder, we can reduce their risks to their health by switching them to buprenorphine for their chronic pain. And I would highly recommend checking out the VA 2022 guidelines that came out just shortly after the CDC ones did. And they have a little bit of a different approach and a different perspective, but I think they have some good points to make. The VA guidelines specifically say they do not recommend initiating opioids for chronic pain. They do not recommend it. However, if they are going to be used, they recommend first line that buprenorphine should be used as the opioid of choice to treat chronic pain rather than other full opioid agonists due to the safety profile of the medication. And I would recommend, checking out their guidelines. They have some different things. They specifically talk more about assessing things like risk of suicide and self-directed harm, risks of pain catastrophizing, the risks of that it's more risky to start these medication in younger people. Younger people who start chronic opioids are more at risk for developing opioid use disorder than people when they're started older. So I think that these guidelines have a lot to offer, and they're slightly different than the CDC guidelines. So I would check them out. And this is from the National REMS curriculum for safe opioid prescribing. They have this toolkit online that is really useful. So if you want any kind of like screening tools or monitoring tools to utilize in your practice, this link has pretty much all of those tools listed on it. So it's a great place to look for those resources that you can use for ongoing care and monitoring of these patients in your practice. So I'm going to stop there. I might have gone over a little bit, but see if folks have any questions about that.
Lots of thoughts about that. I don't know. Do you want to start, Heather, or do you want me to start?
You can go for it.
Somebody did ask, like when you switch somebody over from full agonist to Subutex or even Suboxone, it's very similar. Do you have a way that you kind of just, dosing wise, where you come up with a dose? I think that to me, it's more of a feel, but do you know of any tool?
Yeah, so there really isn't. There is no calculator that's validated for calculating a switch from buprenorphine dose, from full opioid to buprenorphine dose. And so if you look on the websites for the FDA approved therapies of the Belbuca and Butrans, they do have, charts that will say if this person's on this MME. So I think Butrans generally, if someone is meant for people who have really low levels of tolerance, and I think it's a great option if someone's on a low level of tolerance, but I think most of these folks that we're switching over probably are above that. So they're probably above, the 40 to 50 morphine equivalents, those folks we're most concerned about. And I haven't seen any insurance company at least in my state, pay for the Belbuca formulation, but it is kind of nice in that it's this nice kind of in-between dose of kind of the low to medium dose of buprenorphine compared to the sublingual. So it's a sort of a nice bridging in the dose options, but it's so expensive. I haven't had any insurances pay for it. So in many cases for these patients, I generally just go with sublingual buprenorphine, and and I like the strips because they're easier to cut, especially when titrating up on the therapy. We can cut them into different size pieces. So I think that the key with this is there's no way to know for sure. And if you're wondering where even to start, maybe call a colleague that that prescribes buprenorphine a lot to say, hey, where would you start this patient? But buprenorphine comes in generally 2 milligram and 8 milligram doses. So I might start with and just a very, I think the thing is here is that frequent short follow-ups. So in that first week, I might want to see that patient a couple days in that first week to talk about like how did the first day go? How did the next day go? Which we would normally do over telemedicine probably, so the patient wouldn't have to travel. But to understand that we don't know how much it's going to be, but the nice thing is about buprenorphine is that we can basically titrate up to as high a dose of we need of, up to 24 milligrams and it still be paid for by insurance. And I've had patients, like I had a patient on like 500 morphine equivalents, and he really high functioning, super stable guy. And he ended up on, more buprenorphine than his insurance would pay for. Like I think he ended up on, 32 to 40 milligrams a day to control his chronic pain, but he was able to pay out of pocket for the amount that was over 24 milligrams a day. So the short answer is that there's no calculator, and to just start with a low dose with the understanding that it is, safe to rapidly titrate up, but it's also going to take a few days, 3 to 5 days of being on a steady dose before the levels max out because it's a long acting medication. And
I don't know if you were answering something else too. Now, do you use, well, one thing I want to comment on really quickly about, the prior auth with using like a Subutex or Suboxone for chronic pain is if they have any history of any use disorder, whether it's alcohol, even if it's like 30 years, recovery, putting the diagnosis of history of substance use disorder works for using a buprenorphine for chronic pain, because it's almost like you're giving them without having to give them an opioid use disorder. So if you use the very vague addiction diagnosis, prior auth won't kick back.
I think that
also tie it to the pain too, but sorry, Sarah.
Yeah, no, absolutely. So you can, there's so like, I've been very, like, I don't think I've had any prior auths refused in the last couple of years. Insurance companies are much more open. Now you can specifically cite these CDC guidelines. Like they say that this is what we should be doing. So generally what I write in these patients, assuming that this patient doesn't have a history of substance use disorder, right? Like, but they have other risk factors, right? Maybe their age, maybe they have pulmonary disease or cardiac disease or whatever their comorbidity or just their MMEs, and saying, this patient is unwilling or unable to tolerate an opioid taper, or their current dose is acutely unsafe for them. And specifically to write in the prior authorization, this person is currently at a very high risk of overdose. And by switching this is going to dramatically reduce their mortality risk. And that I haven't had any of them refuse just on the basis of that. So I think, and you can specifically cite, like, these guidelines say now that we should be doing this. More guidelines said that before, but not as clearly as these guidelines do. So, and there's been a few cases, like I've had a patient who had chronic pain and he just really, really wanted to be on Sublocade. He just, like, that's what he wanted because he didn't want to take a medication every day. And we, in those cases, I have given patients the diagnosis of opioid and specifically changed the verbiage of the diagnosis to say, this patient has physiologic opioid dependence without opioid use disorder, because that was the only way that their insurance would cover that particular therapy. But in those cases, I would always get consent from the patient to put that in their chart that's saying, you have the diagnosis of opioid dependence, but not opioid use disorder, because that's how your insurance is paying this. But you have to be really cautious about that, because then their medical records go on someplace else and it looks like they have opioid use disorder, but they do not have opioid use disorder. So if you're going to do something like that, you have to be really clearly outlined in the chart that there is not an opioid use disorder.
There's a question in here about naloxone with, opioids in Minnesota. They're not automatically. Patients can go to the pharmacy and ask for it. I know a lot of EMRs now are going to trigger that naloxone prescription at certain levels. It's always a good idea to just co-prescribe it, but tell your patient you're doing it first. I think there's been some stories where patients go and they're like, what? Because they have the stigma of, you think I'm using this, whatever. So what do you guys have in Alaska, Sarah? Is it automatic or is it kind of one of those things that we
don't have any automatic triggers right now. Yeah, you have to manually do it. So it's covered under Medicaid and all the insurances, but yeah, there's no automatic programs in place in our state either. And
there you go. Tim, College of Pharmacy just commented that the Board of Pharmacy they can also do it, the pharmacist.
Yeah, the pharmacists can do it at their own judgment. Yeah. And I think, someone mentioned about like, you may run into insurance issues or pharmacy issues where like, hey, we just won't fill this because it's too high in MMB, like we refuse. So that's like, even if you think it's okay, if the patient thinks it's okay. I had this issue recently with Walgreens here in Alaska that they absolutely refused to fill over certain MME, even though the patient was completely stable. They were really, it wasn't really sort of palliative care, but not really, like they're not just about to die, but they have a very limited quality of life. And they didn't care what I had to say. They absolutely refused. So, you find new pharmacy, but there are cases in which, if the patient, really you don't have a choice, you can't continue those opioids. Patients, multiple studies have shown that when patients transition from full opioid agonists to buprenorphine, they tend to do just as well or better with their pain control than they did on their full opioid agonist. And I've had so many patients who did not have addiction, and some that had chronic pain, that I switched to buprenorphine just for pain management. And the vast majority of those patients were more highly satisfied with their pain management than they were when they were taking. They say it's more steady. I don't have the ups and downs. I don't have the clouded headedness that I used to have. It's shown to have less side effects, and actually, I think because of the way it works on kind of like on some of the other opioid receptors as being antagonists or partial agonists, it's not the same level of risk probably for opioid-induced hyperalgesia and for escalating tolerance. So people tend to be a little more steady on their dose and not have this ongoing escalation of dose for some reason on buprenorphine, which I think we don't totally understand why, but that helps have the conversation.
What does your transition look like then for that? Because, you are going from a full agonist to a partial agonist, and, what is your, how much into withdrawal are you making them get to like do the induction? And what is kind of your patient, like a patient who has no use disorder that you're transitioning? How do you have that discussion with them?
Yeah. So I usually have the discussion of sort of the traditional start instructions that we might also give for a patient with opioid use disorder, like, hey, stop your meds, wait 12 to 24 hours, and then start, until you have moderate or 3 or 4 symptoms of withdrawal, moderate level withdrawal, and then start your buprenorphine. But increasingly, especially for people who are on really long acting high dose opioids and who have really significant underlying pains, and they're very, very fearful and anxious about the idea of stopping their medications, to actually do a low dose overlapping initiation, or what we might call microdosing, to allow them to continue their extended release oxycodone or their extended release morphine for that first week, while you very slowly increase the dose of buprenorphine, starting at 0.5 milligram a day or less, and then doubling that dose every day until you get to the desired dose, and then stopping the other opioid agonists. So they have that low dose overlapping start, and then there's no requirement to go through that period of withdrawal prior to starting, and possibly less risk of precipitated withdrawal as well, is kind of the idea behind that.
Sarah, one of the interesting things that I think that anybody in an addiction office has seen is that if you get patients that get sent to you and they're taking too many opioids and they clearly have an opioid use disorder, and you switch them over to Suboxone or Subutex or what have you, often we find that they are overusing that as well. And some of it may be that they realize that there's that more immediate effect for the anxiety from Suboxone. How do you manage the overusers, especially in view of the fact that insurances will not fill it early?
Yeah, so I think that patients who, like, even if you're on a pretty high dose of buprenorphine, if you're on sublingual buprenorphine, when you take an additional dose, you feel some effects from that. Like it's going to help relieve your pain at that time you take it and your anxiety, and it treats lots of different symptoms that you're having. So people can use that just like they did other medications to self-treat those unpleasant symptoms at the time. And so if we're not able to, if a person really isn't able to control their use, and they understand like, hey, this is the only amount you can get for the month. Some patients may do well with short prescriptions, maybe only a week or two at a time, and it just stays that way so that if they run out, they're only out for a day or so. But in patients that continue to struggle with that, I would definitely, if possible, I would switch them to Sublocade, just because, and I have patients with chronic pain who are on Sublocade, but also have some PRN doses of sublingual buprenorphine, like pretty low doses. And it's set at like, this is the amount that you get. So like save it for your worst days, because they just, and it's really, there's no very, very high dose buprenorphine is incredibly safe. The issue is payment. It's not, it's, and you do get, when you take PRN, even when you're on high dose, when you take PRN buprenorphine, you're going to get some increased levels of pain control. The analgesic effect of buprenorphine is short. So I have had patients where we've had that kind of compromise, that like just your steady state on Sublocade, and then we have small amounts of like PRN dosing that you can take, for the worst days, but their main quantity of medication is just delivered in the monthly fashion. And I think they would qualify for opioid use disorder for sure at that point, because they can't control their use of their medication.
Other questions anybody has that they want to throw out at Sarah before she goes? Heather, do you have any others?
No,
yeah.
There was a question in here though about, sorry, John, go for it.
Thanks so much, Sarah. It's a really fantastic presentation. And I did have a question about people who have allergies to NSAIDs, and how do you determine that allergy? And then what do you do instead? Because sometimes people think they have allergies, they don't. Some people do have allergies. So just wondering how you manage that. Oh, you're muted.
Sarah, you're muted.
Sorry about that. I'm not an allergy specialist, but a patient was truly like, I have like a true allergy, like an anaphylactic or like serious, I don't know how I would go about determining that myself. And if that was like a true, like, I thought like this would really, depending on their disease process, right? Like, I really think NSAIDs would be highly beneficial to your pain, given your disease process. Then if they were willing, I might send them to like an allergist, maybe to test for that in some way. I don't even know if you can test for that, but I definitely have patients, that like, they can't have those other things. Cause maybe, they have alcohol use disorders, and they have varices, and they have peptic ulcer disease, but also they have liver failure, and they can't take a lot of there are places where there are very legitimate reasons why a patient cannot take either acetaminophen or NSAIDs, both which would be the treatment of choice in that circumstance. And so your hands are tied and you're kind of stuck. And so I think those are situations in which if you decide that this person's only option that they have left is opioids, that buprenorphine is going to be the safest one to start. If you have, like, I try to start no one on new opioids for chronic pain, but in those rare situations in which, like, if you think like it legitimately is needed, then buprenorphine is going to be your safest option for that if you have to do that.
Go ahead, Heather. Did you want to do that?
There was a question in there about like the pain contracts and all of that. Now, did you guys edit yours at all to kind of add the whole partial agonist, or you kind of just left them all be? Because I mean, essentially you're going to hope to watch for the same thing, and ours became much less punitive over the years. But did you make any changes with transitioning to the partial agonist meds, or are you still using them at all?
So we still use treatment agreements for all of our controlled substances. And I think that, in general, I think they're useful because they really help to outline what the expectations are, both for the provider and the patient, but also, so we have, I don't know that we have almost no patients on chronic opioids at our particular clinic that we're at, but we certainly, like, within our ones for OUD, we outline the situation in which we may need to change therapy, which I think would be similar like for chronic pain. Like, if we find that you're experiencing, opioid-induced hyperalgesia, or that you're having trouble managing your medications, that you're you're taking more than prescribed and running out, and that you're having these problems and you're having trouble meeting these expectations, that might be a situation in which we recommend a change of therapy to a medication such as buprenorphine that would, is a safer medication. So I think outlining that up front when you're having that very first upfront discussion about opioids or renewing your treatment agreements, to say like, these treatment agreements that just say like, you need to do A, B, C, and D, and then they don't say, what happens next? Like, what if you don't do that? What happens? It's not, we're not going to just rapidly discontinue the medications. We're not going to do that, right? So if your current treatment agreement says like, I'm just going to cut you off of these medications if you don't do it, that's not following any new guidelines. And that's not what you're going to do in that situation, hopefully. So if you have a treatment agreement that says, if you don't abide by these our expectations, it shouldn't say we're going to just cut you off from therapy. It should say that we're going to have a change of therapy or taper, that because cutting people off from their medications would not follow the current guidelines.
All right. I think we may have gotten through every question that was thrown at you. Anybody else? Anything before we go? We got about a couple of minutes here, but people are done. We can sure end it a little bit early and give you some of your day back. One new message.
Just thank you. All right. Well, thank you, Sarah. I hope your meeting goes well and you can go back into the noisy building. I've done a few echoes from my car before, and it happens. And then, everybody, next week we have Dr. Sarah Pauly back, who was with us last week, but she's coming back to talk about adolescents, youth with opioids. So will be another good topic.